Welcome back to part 2 of the neurology lecture. I hope you had a nice bathroom break and we're back at it. In this section, we're going to look at impulse transmission, so how that electrical impulse travels. We've already kind of introduced you to the idea of the continuous conduction or the saltatory conduction. Now we're going to kind of dig into it a little bit deeper. I know there's going to be points where I'm probably going to switch off of you being able to see me, and we're going to talk through it because I'm probably going to do some drawing to kind of give you some ideas of what's going on. But without further ado, let's get started. So last week we did talk about the impulse conduction, and today we're going to talk about how we jump from nerve to the muscle. So we're going to look specifically at what happens at the end of that synaptic knob, or that synaptic terminal, if you will. So when the information travels down that axon, it's going to end at what we refer to as the synaptic knob or the synaptic terminal. So you're seeing this little nerve, and it comes down here, and it actually attaches on and sends that information down the dendrite and onto the next nerve. But this is how this happens. Inside that synaptic knob, you have these little vesicles, and you should be kind of familiar with vesicles. We talked about the term in the the cytology lecture, but the vesicles are filled with a neurotransmitter, and that neurotransmitter has the ability to jump across that gap. So your nerve does not directly touch the next nerve or the muscle or whatever it's going into. There is a very small little gap. That small little gap, you have to be able to jump that gap to get the signal to continue on. And we do this through neurotransmitters. So it transmits the information across, or jumps across, that synaptic cleft. And you can see that word here on the slide. In the case of someone who has Lou Gehrig's disease, or amyotrophic lateral sclerosis, ALS for short, if you have someone who has ALS, those synaptic clefts are getting wider and wider. So it's almost the axon and that synaptic knob starts to withdraw and pull away. So it gets to a point with amyotrophic lateral sclerosis, or ALS, Lou Gehrig's disease, that the neurotransmitter just can't jump the cliff anymore. It can't jump across. And if it can't jump across, then the signal starts to slow down and completely stop. So that is a terrible, terrible disease if you're familiar with it at all. It starts with usually a foot drop, and it's because that's where those nerves first start to pull away, is at the furthest away from you, and then it starts to progressively work its way up. The bad thing with Lou Gehrig's disease is it actually causes the person to be trapped within their brain, because their brain is still able to comprehend, it understands everything that's going on around it, but you lose the ability to interact with your environment, and you get completely bedfast because you can no longer move, and then eventually it works its way up and it starts impacting the muscles that control your ability to breathe. So a lot of times your Lou Gehrig's patients die of other things like pneumonia, or they lose that ability to breathe long enough and that doesn't get caught, so they end up dying of that reason. Most patients with Lou Gehrig's disease die within 2 to 3 years. It's very rare that you have someone that lives a very long time. We've seen it happen. We know it does. You had the brilliant scientist that was in the wheelchair forever. He had Lou Gehrig's. But that is how the information gets passed, is through these neurotransmitters that will jump that little bit of a cliff here. It'll jump across, and it connects in with these little receptor sites on the other side. So it sends the signal on. Now there's several different neurotransmitters out there, but we're going to focus as paramedics on 2 particular types. You have one that's called norepinephrine, not to be confused with the norepi that you think about on your truck, like vasopressin, for example. Excuse me. Or you can talk about acetylcholine. So there's 2 neurotransmitters we're going to focus on as paramedics. One is norepinephrine, one is acetylcholine. Let's kind of dig into those guys. So with norepinephrine is used, or it will respond to adrenergic receptors. So remember, you have a neurotransmitter, you have this little chemical that's bouncing over the cleft, and it's going to connect with a receptor. If the receptor can react or respond to it, it's called an adrenergic receptor site. And I'm trying to emphasize the adren because we think about adrenaline. Adrenaline is about making you fast. Epi is peppy. It's part of your fight or flight response. So we are intentionally impacting the sympathetic nervous system. So all the things that you would expect to see when you have a fight or flight response. That's what's going to happen here. Now, when paramedic students forget they have 14 new drugs to learn in 4 hours, your fight or flight kind of kicks in and you start to panic. So that's part of that. Your norepinephrine is starting to fire. That's the point of this one. In the case of norepinephrine, if it was constantly being transmitted, then you would be in a constant state of flight or flight. That's not necessarily a good thing. We found it to have a lot of bad side effects. Cortisol increases, it causes a lot of problems. So not always a good thing to do. Just like getting information in paramedic school, there's a lot of it, so we're starting to panic. That's the case of it. But how do we stop that transmission? Because as long as those vesicles are open, they're just going to keep sending the norepinephrine across the cleft. So you have to have something in the body that says, okay, it's time for it to stop. We can stop now. And that is called monoamine oxidase, or MAO. And MAO will come into the cleft and it will say, okay, this is enough. And it's going to force the vesicles to reabsorb the norepinephrine. Okay, so that is the purpose of monoamine oxidase, or MAO. And let's just kind of enhance that or think about that process just a little bit more. Have you ever heard of the thing called MAOIs? Usually in those pharmaceutical ads, they say most of your medication is not to be used with MAOIs. What MAOIs is, the I stands for an inhibitor. So it's actually inhibiting the monoamine oxidase. So guess what you have this constant barrage of? Your fight or flight. So early on in the process of learning about different medications and how to treat different diseases, monoamine oxidase inhibitors, or MAOIs, were originally used to treat things like depression. Because if you stayed in a peppy state all the time, you're not going to have time to be sad, depressed, and bored. So the theory was if you keep them going, you suppress the monoamine oxidase, then they're going to keep in this constant mental status, and they're not going to become depressed. But what they found is that causes a lot of not so good side effects, and they found other medications that are far more effective, like your serotonin reuptake inhibitors. Serotonin is another one of those neurotransmitters out there. We're not even going to talk about that. I only want you to worry about two, and that's norepi and acetylcholine. So remember, your monoamine oxidase is meant to go through and tell the vesicles to reabsorb the norepinephrine and stop the stimulation, the fight or flight stimulation. Now, that covers norepinephrine. Now we need to talk about the other neurotransmitter that's called acetylcholine. So if you have acetylcholine that's being released from the nerve, the receptor sites on the other side that are specific to acetylcholine are called cholinergic receptors. And this acetylcholine, and I'm kind of telling you a partial truth here because acetylcholine is seen in certain situations that have to do with the fight or flight, but we're just going to focus on this for right now. Your acetylcholine is used by cholinergic receptors. It connects into it, and it's part of our feeder breed. It's part of that parasympathetic nervous system response. So acetylcholine is meant to kind of slow things down and kind of chill things out. And just another moment of acetylcholine, you're kind of dragging and you're laying down and you're trying to take a nap. So that's part of that parasympathetic nervous system. Now, going back to the previous lecture, we talked about organophosphates. So if you have this constant barrage, we talked about the poisoning. If you have this constant barrage of the feed or breed, then you're going to have this constant state of sludge. So that's salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis. So you've got this constant state. So we, just like with norepi, we have to have something that's going to stop that transmission and allow it to be reabsorbed so that we can move on. And how do we stop that transmission? It's through something called acetylcholinesterase. So it's very easy to remember if you see the erase on the end. So we're taking that acetylcholine and we're erasing it from the synaptic cleft. We're forcing the vesicles to reabsorb the acetylcholine. Now, how do we use this as paramedics? Quick review on this. Here we go. Remember, the neurotransmitters are related to the peripheral nervous system. So we talked earlier about the peripheral nervous system having the somatic nervous system is responsible for skeletal muscle. We have voluntary control over that, or at least a portion of that. The autonomic side we do not have control over. So that's where this kind of gets fun, because this is how it impacts you as a paramedic. So on that somatic nervous side, remember S for skeletal muscle, we have voluntary control. We're going to set that over there. The autonomic side gets broken into two categories. You have the parasympathetic and the sympathetic. You have your fight or flight or your feed or breed. You do not have control of this. These are the signals that are telling your stomach to digest the cheeseburger you just ate. It's those types of things. These are things we do not have control over. Our organs are working according to that autonomic nervous system. So again, you've got the fight or flight, which is your norepinephrine, and your feed or breed, which is acetylcholine. Now, let's talk about what you would expect to see here. I'm going to pick up the next slide. I may end up drawing here in a minute. We'll see what happens. So in this situation, if you're looking here, you'll see the parasympathetic side. We just got it located over here to make it easier. Okay, so we've got the parasympathetic section over here, sympathetic over here. Now what I want you to do, this is your fight or flight. I want you to look at that fight or flight, and I want you to see exactly where that fight or flight originates. Remember, this is part of the peripheral nervous system. So you've got this brain and spinal cord. All of those signals for the fight or flight come out here between T1 and about T2-ish. But you can see these are located right here at this section. And the sympathetic control is going to impact all kinds of things. We're going to talk about that here in a minute. On the parasympathetic, this is your feed or breed. So this is about slowing things down. This is speeding up. This is slowing them down. You do have your eye control, all of this stuff. Same kind of thing that you're seeing over here, but you'll see that it actually exits up here at the top. It exits down here at the sacrum. So those are the types of areas where you're going to see this happen. Now, let's kind of dig into this a little bit more. Why do we care? I want you to think about, and I think what I'm going to do is I'm going to pause the video and I'm going to come back in. I think I'm going to stop the video. How am I going to do this? I'm going to stop the video and I'm going to come back in and I'm going to do some drawing. Okay, so I'm going to do some drawing here, and I'm going to start out with my laser pointer. So let's go back over here and let's talk about the sympathetic nervous side. We know that the sympathetic nervous system is all about the fight or flight. So this is speeding things up. We're going to speed up. It helps when you don't hit the eraser. It's really hard to see. Let me see if I can find something that's a little bit brighter. Speed up, that works. Okay. So in this situation, what do you think is going to happen? What's going to happen to your eyes? If you're in a situation where you're in a dark alleyway and someone is coming at you with a knife, your eyes, you're going to go into that fight or flight mode. Your eyes are going to dilate. So you're going to have the eye dilation. Your skin, you're going to see that you're going to sweat. The theory is if that big scary person can't catch you, then you can get away. So you're gonna eke sweat, and that's gonna keep you slippery and keep you from getting caught. Okay. Then you're gonna have, we don't worry so much about the salivary glands here. Maybe I should put my glasses on. This will help a little bit. But we do want to talk about the lungs. So if you're in a case of fight or flight, you've met this guy in the dark alleyway, your lungs are going to broncho, what do you think they're going to do? Are they going to bronchodilate or are they going to bronchoconstrict? We need them to dilate because we need as much oxygen coming in as possible because we have to feed those skeletal muscles. We want to run really fast. So guess what happens with our heart rate? Our heart rate in a fight or flight situation is going to increase. So the heart rate's going to speed up. That's going to allow us to get that oxygen down to the legs so that we can run faster. Here's my silly little foot so that you guys can make fun of my foot. That's more like a claw, but you get my point here. We're trying to run really quickly. Now, what happens at the stomach? If you're in a fight or flight mode, what's going to happen to your stomach? The stomach is you're not going to have the gastric juices flowing. It's going to stop. And here's the other thing that will happen. Because the motility of the stomach stops or decreases, you stand a risk of vomiting. So if you've ever been in a situation, or you know someone who's been in a situation where they have gotten really nervous, they may have vomited as a result of the nervousness. That was part of their fight or flight that kicked in. The same thing if you see someone pee themselves. If they pee themselves as part of that fight or flight, they're trying to lighten the load. If they are lighter and they don't have that pee in that bladder, they may be able to run faster. So that's the goal here. So you can kind of see how this works out to our advantage if we're trying to run away from the danger. So we're trying to get away from the danger. We want to speed up. We want to go faster. Okay. On the flip side to this, so let's go and let's look over here. If you're dealing with your parasympathetic nervous system, this is part of your feed or breathe. So in this case, everything starts to slow down. And if it slows down, your eyes will do what? What are your eyes going to do? They're not going to dilate anymore. They're going to become more constricted. So they will constrict. What's your heart rate going to do? Let's do HR for heart rate. Your heart rate's going to drop. Your lungs, what's going to happen at your lungs? Your lungs are going to bronchoconstrict to a degree. Now, they're not pinched down like in the case of asthma, but they're going to be more relaxed. And then what happens with the stomach? The stomach motility is going to increase. So that's when we're more focused on stomach. We can digest our food, we can work through things, and it just goes a little bit better. So those, again, this is just to kind of remind you of the impact these guys have. And we're going to move on. So how does this relate to you and what you do in your job? We know that the autonomic nervous system also has another branch. and it's called the parasympathetic nervous system, right? But right now we're going to put our attention directly on the sympathetic nervous system, which we know is supposed to be our fight or flight, okay? And that sympathetic nervous system, again, can't be simple. We gotta make it even more difficult. You actually have two different types of receptors over here that deal with this. You have one that's called an alpha receptor, you have the other that's called a beta receptor, and they do very, very different things. So here is what you need to commit to memory. Are you ready? You need to remember that anytime you see the word alpha when it's relating to the sympathetic nervous system, this means constriction, okay? And anytime you see the word beta, when it relates to the sympathetic nervous system, you need to think dilate. So alpha does what? Alpha constricts. And then what does beta do? Beta dilates. Now I want you to ask yourself a simple question. How many hearts do we have? The answer is 1. Okay, so we have the number 1. And then how many lungs do we have? We have 2 lungs. So let's see how this relates. So again, if we're looking at the sympathetic nervous system, oops, excuse me, let me get my drawing device out here. If we're looking at the sympathetic nervous system, and we say we've got 2 different types of receptors, one is an alpha, the other one is beta, and we know every time we see the word alpha, alpha means constrict, okay? And every time you see the word beta, we think dilate. So if you see something that says, if you have a receptor that is alpha 1, that means that you have constriction of the heart. So we're talking about the vasculature. So in this case, alpha 1, if the alpha 1 receptor is triggered, you have vasoconstriction. So you're going to vasoconstrict. Okay? Now, you get a freebie here. You don't have to worry about alpha 2 ever, so don't worry about it. In the case of beta, let's go over here and look at beta. So if you have beta, we know beta dilates. If the receptor is a beta 1 receptor, that means, what do you think it does to the vasculature? In beta 1, that causes vasodilation. Okay? And then you also have beta 2, and we know that beta 2, we're talking about dilating. And what are we dilating? We're talking about dilating the lungs. So we're going to dilate the lungs. So it depends on the receptor that's being triggered as to the result that you're going to have. So let's go to the next slide. So you'll see here in this little picture, you've got the alpha. This is alpha vasoconstriction for alpha 1, vasoconstriction. Beta 1 means that you're going to have vasodilation. Now, what that means, and I want you to think about this, if you think about your vessels as nothing more than a container, so let's just kind of imagine this as a glass or a pop bottle. That's even better. Let's talk about a pop bottle, and say you've got so much fluid in that pop bottle and it's nice and full. That's what you want to think about your vessels as. They are a container. But if you get cut and you're bleeding profusely, if you're bleeding profusely, what happens to your volume? Your volume starts to decrease. How does your body fix that? How does your body fix it? It fixes it by creating vasoconstriction. So with the vasoconstriction, that is your body's first way of maintaining the container and keeping that container full of fluid. So Think about it in terms of a container. And if you've ever messed with a sump pump, you know that if you get air in the line, it won't pump, it won't act as a good pump. So in the case of, um, bleeding, you want to have the vasoconstriction, okay? And then as a result of the fight or flight, you're going to have an increase in the heart rate because you've got a situation on your hands, so you're going to increase the heart rate, and that's going to increase the contractility, or how easy this heart is to contract. And then you're going to see the bronchodilation. The lungs are going to bronchodilate because we're going to try to pull the oxygen in as easily and as quickly as we can, because we know that we're in a state of fight or flight. We've got to fix something. This is going to bring the oxygen in. So it's going to open those bronchioles up to allow that oxygen to flow in easier. We're going to increase the heart rate so that it can pump that blood down through the vasculature, and we're going to try to vasoconstrict a little bit to maintain that container. So that's kind of how that works. So how does any of that relate back to medications that were given to our patients? So let's look back at the case of epinephrine and your albuterol, for example. So in the case of epinephrine, we already know that epi will make you peppy. It emphasizes or stimulates the fight or flight response. Because it's stimulating the fight or flight response, it's called a sympatho, because it's sympathetic, mimetic. So epinephrine is mimicking the fight or flight. It's a sympathomimetic. It stimulates both alpha and beta receptors. So this is why epinephrine is great for asthma exacerbation in the form of racemic epi, because it allows for the bronchodilation you get with the beta response, the beta 2 response, okay? But because it triggers both alpha and beta receptors, you can have some adverse effects, because you can have cardiac ischemia. Remember, we do have some vasoconstriction as a result, and that vasoconstriction can lend itself to hypertension, and it can cause heart palpitations. So you can have those premature ventricular contractions. Now we can also talk about albuterol, because this is one you've seen as an EMT. So albuterol is actually considered a non-selective because it's not picky. It's a beta agonist, so we're talking about that particular sympathetic nervous system branch, that particular receptor. It will ag it on. So agonist, it's going to ag it on. But it's non-selective, so that means that it affects both beta 1 and beta 2. And it is great for asthma exacerbation because it's going to give you the effects that you want to see from the beta 2, because beta dilates to lungs. So it's going to give us the bronchodilation we need. But what does beta 1 do? Beta 1 has vasodilation. When you dilate the hearts, what's going to happen? You're going to have to increase the heart rate to keep the container full. And that can create as the adverse side effects as increased heart rate with the palpitations. So that's why they get so agitated and stuff with the albuterol. And I hope this has helped. I hope this has helped because you only have one more lecture for neurology left. So I hope this has been a decent review for you. If you have any questions, please write them down so we can get into it. Thank you.